Hi everyone, we're going to talk about men's health, and in the book that's chapter 49, 50, and 51. So the first thing that we're going to talk about is nocturia, and that is the frequency of needing to go to the bathroom at nighttime. The biggest issue with it is that it can disturb your abnormal sleep. With your patient, it's important to talk with them about the number of times that they're having to get up at nighttime to go to the bathroom. For adult males, it's normally that they would void 5 to 6 times during the day and once or not even at all at nighttime. So their expectation of what is disrupting their sleep may be not as the same as what you think it should be. Some causes of nocturia could be related to your prostate. You can have nocturia without discomfort, and that can be related to your bladder capacity or an overflow incontinence. It can also be related to habit. And in the absence of nocturia with increased frequency, you have to rule out that there could be a psychogenic origin. There could be a polyp or a lesion in the urethra that is improved when they are up and moving. Some common causes: decreased bladder capacity, increased urine that's sitting in the bladder, or involuntary bladder contractions. If you have a gentleman who is complaining of dribbling, this may indicate an overflow from a partially incompetent outlet and could be acquired or congenital. Hold on here. Some other causes are weakness of the detrusor muscle, having infections such as with Klebsiella pneumoniae, Proteus mirabilis, Enterobacter, Staph, Enterococcus, and Pseudomonas. Certain medications can cause nocturia and incontinence, and those could include methyldopa, phenothiazides, Valium, and diuretics. Treatment first is to identify what the cause is. Urinalysis is simple and easy to rule out a UTI. You might consider doing a PSA and a digital rectal exam to rule out a prostate problem, and based on the results will indicate if you need further testing. Let's move on to testicular pain. Gentlemen may describe that as a fullness or a heaviness in the scrotum that could range from an achiness to a sharp pain. It can happen in a wide variety of gentlemen. There's no differentiating circumstances that you will see. A hernia can occur when an evangination of the peritoneal cavity occurs and occludes the spermatic cord. And evangination is when a part turns outside or inside of the membrane of that area. So that's what that's referring to. And based on anatomy, if the gentleman has a patent processus vaginalis, that can make him more predisposed for hernias. Some of our differential diagnoses for testicular pain can include swelling of the epididymis, torsion of the testicle, a spermatocele, or a syphilitic guma, which is similar to a varicocele. If you look here at the picture, we have a normal testy and epididymis on the left, and then we have a more inflamed epididymis and swollen testicle here on the right, just as a visual for you. Other differential diagnoses for testicular pain includes a hydrocele, varicocele, epididymitis, prostatitis. We're going to talk about hydrocele and varicoceles later on in the presentation. With prostatitis, pain is usually in the lower back and can radiate into the testicle, and with those gentlemen, you often see a fever. If you were doing a culture on that urine, it's usually showing E. coli. Treatment of the testicular pain is dependent on what the underlying cause is, and then you can treat appropriately. So also with gentlemen, you are going to be seeing folks that have BPH, benign prostatic hypertrophy, and that's a nodular hyperplasia of the prostate, and it's a very common finding in gentlemen 40 and older. It happens in the transitional zone of the tissue of the prostate. On our next slide, we have a picture of the prostate and the urethra. So when they're grading the BPH, they consider not only the size of the prostate, but also the decreased urinary flow and if there is post-void residual urine in the bladder. So that picture's coming up. Anyway, BPH can be graded by the International Prostatic Symptom Score, and there are different components that are used, as we talked about, to make that classification. Decreased force of the stream, hesitancy, post-void dribbling, sensation of an incomplete bladder emptying, overflow incontinence, frequency, urgency, inability to stop the urine stream. Irritative symptoms can cause BPH as well, whether that is nocturia at needing to go to the bathroom at nighttime, urinary frequency, urgency, dysuria. But the picture that I like to show is the normal diagram. Here on the left, you have the bladder, the urine coming down into the urethra, and the prostate on both sides of the urethra. But with BPH or prostatic enlargement, you can see how this narrows down the opening here. So it is more difficult for urine to be able to pass through and give the gentleman the all of the things that we have been talking about, that sense of urgency, not emptying, where you could possibly have dribbling. When these gentlemen present, it's important to do a digital rectal exam to determine the enlargement of the prostate. Normal size of the prostate should be about a walnut. You also want to make sure, rule out that there is not any blood in the urine, so the urinalysis is important. An easy non-invasive test, if you're able to get it done. In primary care, you may not be able to, but in a specialty office, being able to assess for a distended bladder with a bladder scan, and then also if there's an increased post-void residual. Diagnostic test that you would do, as we talked about, is a urinalysis. An elevated pH could be indicative of a chronic residual urine. And if there's any obstructive uropathy, getting a chemistry to evaluate the creatinine is important. In BPH, you may see that the prostatic specific antigen is normal and is usually less than 10. Urine cultures may show positivity for bacteria based on the chronic residual urine. In the presence of blood in the urine, urine cytology would be done to rule out a bladder cancer. Medical management for BPH, mild to moderate symptoms, is wakeful watching. Lifestyle changes, depending on the significance of the BPH, are important. Avoiding caffeine and alcohol. It's also important to make sure that they are drinking good fluid intakes. If the patient has a higher AUA score, urinary retention, and complications, treatment may need to be more vigorous. And that's going to include medications, selective alpha-1 adrenergic agonist, a subtype alpha-1 adrenergic receptor targets, and other medications that include 5-alpha reductase inhibitors. All big words, and we probably know the medications a little bit more. Terazosin, doxazosin, with the terazosin or the Hitrin, if that's something you're starting a gentleman on, for them to be aware that that can make their blood pressure fall. Other ones include Flomax, Proscar, Avodart. Education is important. We need to educate them on over-the-counter medications that contain alpha agonist or anticholinergic agents that can increase urinary retention. They also need to be advised to avoid foods such as coffee, spicy foods, or alcohol that could be considered bladder irritants. And equally as important is voiding every few hours, recommended every 2 to 3 hours, to decrease filling of the bladder and avoid that sensation of fullness and decrease the possibility of a UTI. In practice, you're going to have gentlemen that will present with concerns about erectile dysfunction, also could be known as impotence, and this is the failure to consistently maintain a rigid erection to allow for sexual intercourse. I'll let you read the rest of that slide. It can be classified as mild or moderate or severe, dependent on these symptoms. Subjectively, your patient may come in and say he has a loss of desire, inability to maintain an erection, premature ejaculation, unable to ejaculate or achieve an orgasm. For erectile dysfunction, it's important to do a genital exam, assess the testicles to make sure they are normal in size. You want to assess if there's been any hypogonadism noted. It's important to see if they have enlarged breast or any abnormal body hair distribution. You should assess pulses in the groin. If there is a vascular concern from either the patient's history or the physical exam, the next step would be to refer to vascular surgery for an aortogram to assess that area. And it's important to do any test that would reveal any impairment of the lower extremities for vibratory position, tactile, and pain sensation, as that will give more indication. As we talked about on the previous slide, neurological exam is important to evaluate the erectile reflex, including the anal sphincter tone, the perineal sensation, and the bulbocavernous reflex. An examination is needed of peripheral neuropathies. You want to assess sensation to the lower extremities, see if there's any muscle weakness, and to assess the deep tendon reflexes of the legs. Important things to assess with erectile dysfunction is, could the patient have an elevated blood sugar, and you want to rule out that they have diabetes or uncontrolled blood sugars. Lipid profile for dyslipidemia, check their thyroid, and also check their testosterone levels. The management of erectile dysfunction, if you are not able to find an organic cause, behavioral sex-based therapy is an option, but it will depend on your location on availability. Hormone replacements and non-pharmacological interventions to help with erection include vacuum constriction devices, vasoactive therapy, penile prosthesis, and penile revascularization. These are not things that are going to be implemented by you. These are things that are going to be going to a urologist or someone that specializes in erectile dysfunction. And I believe this is just a summary of the things that I said at the end of the last one. Other patient education includes management of chronic conditions, hypertension, diabetes, and stress. Relaxation is very important. Good control of blood pressure and blood sugar, and counseling if needed. Next, we're going to talk about prostatitis, which is can be acute bacterial, chronic bacterial, or non-bacterial prostatitis or prostodonia. And you can also have asymptomatic inflammatory prostatitis. This is a similar picture that we had seen previously on BPH, but you can see how the prostate is more enlarged and how it narrows the urethra there. Prostatitis occurs in sexually active men, typically between the ages of 30 and 50. With chronic bacterial prostatitis, it's seen in the older gentlemen. Athletes who run long distances and have vigorous exercise regimens can be more predisposed to prostatitis, although that reason why is not known. For my personal practice, I have found that older gentlemen that sit a lot, whether they be farmers or truck drivers, are more prone to prostatitis as well. I've seen several gentlemen that have had prostatitis, had those professions. Briefly, we'll talk about the epidemiology. Acute bacterial prostatitis is usually associated with a UTI, has an abrupt onset. Chronic bacterial can just be an ongoing. All the infections are typically with Klebsiella, Pseudomonas, Enterobacter, E. coli, Proteus, Mirabilis, gonorrhea, strep, and Staph aureus. Clinical presentation is that tenesmus, that's spasmodic contraction of the anal sphincter. They can have pain. It can be persistent need to empty the bowel or bladder with involuntary straining. They can have weakened urine stream, incomplete emptying. They can have dribbling, incontinence, and that's common in all forms of prostatitis. It's important to assess for signs and symptoms related to the patient's history. Look on page 755. So it has a breakdown of whether it's an acute bacterial, a chronic bacterial, or a non-bacterial prostatitis on some of the different symptoms that you would see associated with this. A rectal exam should be performed, but with caution, as the area can be very tender, and if infection is noted, can cause septicemia. You will find that your patients are very tender, and it can be quite uncomfortable when you're doing this exam, so lots of lubrication and proceed gently. Some diagnostic tests that you want to do: CBC to look for white cells, a shift to the left, urinalysis, CT, or ultrasound if there's concerns for malignancy or abscess, and then a needle biopsy if anything is found, as always with the guidance of a urologist. Some of your differential diagnoses for prostatitis, I'll let you review those. Also, just a pearl to note that acute prostatitis can mimic acute diverticulitis, but history and lab tests usually can be appropriate to differentiate between two. On the management, if it's bacterial, if the patient has no fever, can be treated on an outpatient basis. If the gentleman is appearing toxic, if he's immunocompromised or has concerns for an abscess or signs of urosepsis, then they need to be admitted into the hospital for treatment. For bacterial, treatment is usually with Cipro until they've been afebrile for 24 to 48 hours, and then they are put on oral Cipro. Levaquin PO can be used for up to 6 weeks for outpatient therapy, as often it is a ongoing process to improve and resolve the organism. We talked about previously being treated for 4 to 6 weeks. Some alternatives would be Bactrim or doxycycline. Important to hydrate IV fluids to be given if the patient is unable to drink. Catheterization is contraindicated with acute bacterial prostatitis due to the potential of irritating the prostate even more. If they are unable to void, then a suprapubic cath would be recommended. In chronic bacterial prostatitis, treatment is best seen with Bactrim, although other antibiotics can be used. And with chronic infection, they are usually treated anywhere from 6 to 12 weeks. Non-bacterial prostatitis can benefit from erythromycin. or being treated with nitrofurantoin. All right, for management on non-bacterial prostatitis, avoiding irritating symptoms, decreasing the use of, irritative symptoms can be treated with NSAIDs, muscle relaxers, anticholinergics, sitting in a hot tub, even sexual activity can help move that fullness through the prostate, and mild exercise, avoiding the spicy foods, caffeine and alcohol, and then if pain continues, a surgical consult. Follow-up: if there is blood in the urine or an elevated, significantly elevated PSA, that would lead to a urological consult. Others that you are managing would need to be seen 30 days after with a follow-up urinalysis and culture. Next, let's talk about testicular torsion. That's where there's a twisting or a rotation of the testes causing ischemia. It's considered a urological emergency, and you can see here that this is a normal testicle. In the literature, you may hear of the term a bell clapper deformity, and that's where the testicle is more flat than up on its axis. But torsion, you can see here from the vessels where it's getting twisted and blood flow is being constricted. This can occur at any age from newborn on up. Most 2/3 of the cases occur between 10 and 20 years of age, with a peak at 14. Some contributing factors may include trauma to the scrotal area. Also, over 50% of patients can have the contraction of the cremaster muscle, which can happen during sleep, which can lead to testicular torsion. Onset is quick. You may see swelling. You may have pain as a gradual onset. The patient may have this pain for several days before seeking medical treatment as well. On exam, you may note that the cremasteric reflex is gone. That is where, if you stroke the inner thigh, that the scrotum draws up. That may be missing. One testicle may be higher in the scrotum or lay it more transverse, like we talked about with the previous picture for the bell clapper deformity. Elevation of the testes does not relieve the pain, and there may be a small lump palpable on the superior pole of the testes, and that's often called the blue dot sign. Some diagnostic tests would include an ultrasound or a nuclear scan, but most often it is diagnosed by history and how the patient presents afterwards. As we know, with the twisting of the testicle, there's compression of the vessels that lead to the testicle, and necrosis can set in within 6 hours if this twisting is not reversed. So it's important to send these patients straight on to the emergency room so that they can get a surgeon involved. Without appropriate intervention, approximately 80% have had the loss of that testicle, and then there is atrophy of the testes in over 10% of the cases. So as we talked about to the ED will work on trying to help relieve the pain and surgical intervention. Conservative management can occur, but it's a much slower recovery, and pain may persist, but that would include rest, ice, and NSAIDs. Moving on, we're going to talk about a hydrocele, and that's a collection of peritoneal fluid within the scrotum. And as you see here in the picture, we have the vessels, we have the epididymis, the testicle, and then we have this collection of fluid here. Causes can be related to nonspecific epididymitis, trauma, a tumor. There's several different causes, if the bladder should turn inside out, that's exstrophy, may increase the risk of a hydrocele. Patients with Ehlers-Danlos syndrome and patients that have a VP shunt are more prone to having a hydrocele. Subjectively, the patient may say there's swelling in the scrotum or the inguinal canal. Often it's painless, even though the patient may report a sense of heaviness. If you transilluminate the scrotum with a light behind the scrotum, you can often see a collection of fluid. It appears light pink, yellow, or red. The testes themselves do not transilluminate, but the swelling also may be noted in the groin or in the upper scrotum. It's important to ask what has led up to this time when they've come in for to be seen about it. Has there been any trauma? You may need to do an ultrasound, a testicular nuclear scan, and abdominal x-rays. Other differential diagnoses include hernias, orchitis, epididymitis, trauma, torsion. Exploratory surgery may be needed to further explore the hydrocele. Management, there's really no treatment for a hydrocele unless there are complications and or if the hydrocele is painful, large, or unsightly. Next, we're going to, patient monitoring at 3-month intervals if there is, to assess if there's been any worsening of the symptoms and if they're going to decide on surgery. Postoperatively, the patient would be followed in 2 to 3 week intervals, and then followed by 2 to 3 months until there's resolution of the condition. Varicocele is our next one we're going to talk about, and that's extreme venous dilation of the vessels in the scrotum. Normal one here, and you see the vessels are all normal in size for the picture, but on the right they look very dilated, very distended, almost ropey, like varicosities of the legs. They're very engorged and can be painful. There's no ethnic predisposition or age differentiation. The variceles can happen in 8 to 20% of the people, and it's related to a weakened wall in the spermatic vein and excessive pressure that can cause this. We have pain, engorgement, and the patient may feel as if they have a bag of worms in their scrotal sac. Lying down, you may not get the true effect, so it's important to have the patient standing up so that the veins can be assessed. They're going to look engorged or feel engorged. You may also need to ask them to do the Valsalva maneuver to have the veins become more dilated. You also may note some testicular atrophy related to impaired circulation. Variceles can be graded, grade 1, 2, and 3. Grade 1 is when they're palpable, only when the patient performs the Valsalva. Grade 2, when the patient is standing. And grade 3, with light palpation and visual inspection. Some diagnostic tests that may need to be performed is a sperm count and motility. If, depending on age, if they are wanting to have children, fertility workup, scrotal ultrasound, and based on these results, whether you would seek out other testing. Differential diagnosis for the varicocele could be a hydrocele, spermatocele, testicular tumor, epidemial cyst, or renal tumor. The management of these is referring to a surgeon if pain is there, if there are concerns for blood flow. Conservative treatment is NSAIDs, scrotal support. The literature states that treatment does not consistently improve sperm count or fertility. complications would be infertility and testicular atrophy, and of course any patient that has variceal infertility pain or testicular atrophy should be referred to urology. It's important to educate these patients on the disease signs and symptoms, how to monitor for any changes in the variceal, and then the importance of wearing scrotal support, wearing briefs versus boxers to help the scrotum and those vessels not be as distorted and engorged. Briefly, we're going to talk about testicular cancer. We're almost done. It can arise from the testicular or adnexal cell components. Tumors can be either germ cell or seminiferous tubules. In adults, mostly it's germ cell at 90 to 95%, in boys 60 to 75%. We have a picture here of the scrotum and the vasculature, the epididymis, the testi, and then you can see here a protrusion of the tumor. We know that the testicle is like a peeled egg, so hard-boiled egg, and that is not allowing for that smoothness, and you should be able to, the patient and you, feel it. Peak age is between 20 and 40. Risk factors are higher socioeconomic status, being unmarried, living in a rural area. May present as a hard lump on the testicle, scrotal swelling, a heaviness in the scrotum, may have pain or sensation of fullness, could be reported as a previously small testicle that has enlarged in size. Generally, testicular cancers are painless, though enlargements. We talked about how it presents a firm, non-tender mass. 10% of the patients may be symptomatic. Another 10% may have concerns for metastasis, such as a cough due to lung spread, low back pain or nerve root or psoriasis, muscle irritation due to retroperitoneal met, or lower extremity swelling. It's important, if you have concerns for a testicular cancer, to do some lab work, biomarkers such as a beta HCG, an alpha fetoprotein, and a lactate dehydrogenase, and LDH, scrotal ultrasound, and then being sent on to urology or surgery for an orchiectomy for staging. Also, if there was a cough, chest x-ray to see what might be showing initially in the lungs. Patient education, that the patient's losing one testicle does not affect their ability to have a prosthesis to simulate the weight and the feel of the testicle. And although surgery to remove lymph nodes is likely necessary, it does not compromise the man's ability to have an orgasm, but it can interfere with ejaculation. Lee talked about, one more. These are options if for having the testicle removed. There is the potential of sterility. Discussion of sperm banking may need to be brought up. It's important that your patient feel comfortable talking about these things with you, and it's also important for all gentlemen to do monthly testicular exams like women do breast exams. Men should do testicular exams so that they know what the feel of their testicles is. Now, Lee had talked about sexually transmitted diseases, so I'm not going to go over these. I do provide the CDC link for the guidelines for STDs in the book on page 780. It gives pathogens, their presentation, and recommended treatment. On to exam 3, there are going to be just a couple of questions that talk about clinical presentation, more of the classic presentations with STDs, what the organism might be, and common treatments. And we have one last slide. on STD patient education. It's important that patients should seek treatment as soon as any symptoms occur, and that patients understand that with active STD infections that they have increased chance of becoming infected with HIV. All right, end of men's health, and thank you for your time.